So hello friends, and you are welcome to this series of our maxillofacial trauma, where we are going to talk about the Lefort-2 fractures. As we move towards the Lefort-2 fractures, we see the complex anatomy comes into the play. Lefort-2 engages lot of bones, like it engages bone of nasal cavity, it engages bone of orbit, it engages maxilla, it engages zygomatic, it engages the pterygoid plates. A Lefort-2 fracture is a pyramidal mid-face fracture that separates the central maxilla and the nasal complex from the rest of the facial skeleton. The fracture line typically passes through the nasal bone, then to the medial orbital wall, then to the inferior orbital rim, then the orbital floor and maxillary sinus. It's come out from this area and then it travels downward over the maxillary sinus or the anterior wall of the maxilla towards the buttress, and below the buttress it will run in backward manner and it fractures the pterygoid plate from the middle half. So this is the entire line of Lefort-2 fracture, a typical Lefort-2 fracture. Mid-face edema and ecchymosis, bilateral periorbital brushing, infraorbital nerve paresthesia or numbness of the cheek and the upper lip. Epitaxis, that is the bleeding from nose, malocclusion, mobility of the mid-face when the upper teeth are grasped and moved, possibly CSF rhinorrhea if associated with the skull base injuries if presented. So, for the diagnosis, the clinical examination and the gold standard radiographic diagnosis is the CT scan of the facial bone. So, coming to the management part, we will divide this in the initial management and definitive treatment. In initial management, we will follow the ATLS, that is the airway breathing and circulation protocols, control bleeding, and assess the associated ocular, spinal or the cervical spine injuries. Coming to the definitive treatment, we will divide this treatment into the two parts. One is the non-displaced fracture, where we will follow the conservative management with observations of diet and the follow-up, and if required, a IMF. On the other hand, that is the displaced fracture, where the open reduction and the internal fixation is the gold standard for us. Coming to the ORIF principles, we must establish a proper occlusion using the intermaxillary fixation, reduction of the fractured segment, and the fixation keys is like to fix the buttresses, like we have to fix the zygomaticomaxillary buttress, that is the zygomaticomaxillary buttress, we have to plate here, nasomaxillary buttress, we have to plate here, and infraorbital rim, we have to plate here. So we will follow a 3-point protocol where we will plate on the nasomaxillary buttress, on zygomaticomaxillary buttress, and the infraorbital rim. Infraorbital rim is the horizontal buttress. So we will restore all the buttresses. Complications which usually occur during the treatment or after the treatment is malocclusion, facial asymmetry, infraorbital nerve dysfunction, sinusitis, non-union or the malunion, and persistent diplopia. Diplopia occurs only in those circumstances where the floor of the orbit during the fracture, floor of the orbit get involved and a major part of the floor of the orbit displaced, resulting in displacement of the eye content in near lower level, which cause the diplopia. Coming to the surgical protocol, before commencing the surgery, we have to be careful about the approaches by which we are going to target the area of the fracture site, and we can achieve direct vision of the fractured segments without disturbing the natural anatomy or the physiology of the body. Here the foremost thing which I want to say is that to get plating in the nasomaxillary buttress, we usually go through the skin or through the eyelid. The scar of the eyelid is quite hidden, but the scar on the skin are sometimes visible. So to make them invisible, always place the incision in the skin creases. Always try to make the incision in the skin creases. There are a lot of skin creases on the forehead, and we will expose this part from here directly on the skin. To achieve the fixation at zygomaticomaxillary buttress or to the infraorbital rim, we have approach of vestibule. So we can go for the vestibular approach, or to approach this infraorbital rim is always that we can go with a subciliary approach or infraorbital approach. The direct approaches give us direct visualization and better control over the plating system. So it's always advisable if there is a lacerating injury around this part, always use that to directly go to the segment and do a plating. Otherwise, you have a lot of indirect approaches. We will study and talk about those approaches in the later videos of this series. Here today we are going to just tell you how to fix the plates over the LIFO2 fracture. So coming to the plating part, as we all know, nasomaxillary buttress, this is a thick bone, it is a cancellous bone, but the choice of plate depend upon it's either 1.5 mm or a 2 mm plate. As this is a quite straight area and there is a sometimes curve here, so we have to adapt those plates, and it's always better that we will adapt the plates according to anatomy to get the best results. Mini plate with 2 mm of size to adapt the plates according to the anatomy, and point to be considered which I was talking is infraorbital nerve. This is the only nerve here in this particular fracture which is most important. Diplopia and then infraorbital nerve. Infraorbital nerve को आपको preserve करना है. Try to preserve it as much as possible. Now we have to bend the plates using the plate bender. Like this, I am bending it slightly upward because this segment is quite below the buttress. So I just want to place it like this here in this buttress region. We always praise the bonker system because the flexibility which they provide us to adapt the plates with minimal effort like this. We have two plates above the apical portion and in the cortical bone. Again using the same crosshead screws with the driver to get the maximum rigidity in this system. We don't have to tighten the entire screw at once. We have to leave it slight loose so that we can better adapt according to anatomy, and we will tighten the all screws after the final placement of all screws done. In real life conditions, it is not that much easier to see on this model because there are a lot of muscles attached in this area. So you have to stretch a little bit to get the direct vision of the area. So once all the screws is in place, now it's time to screw them to the last point where the maximum torque is to be achieved. So we will go one by one. We achieved a rigid fixation. Next, we have to achieve the same thing in nasomaxillary buttress region. We have to adapt the plate again up to the desired position. Point to consider for the screws in this area. What is the length of the screw? So this side there is a eye and this side there is a nasal cavity. And this bone is approximately 6 to 7 or 8 mm thick. So screws here we are going to use is a size of minimum 4 to 6 mm only. Don't try to use bigger screws in this area because there are a lot of anatomical structures both sides and this is a very paper thin bone. Always try to drill the holes away from the eye. Try to be 90 degrees to the both sides. Neither we have to move in the nasal septum nor we have to move in the eye. While doing the nasomaxillary buttress screw on the frontal side, you always consider the thing that immediately behind this frontal bone there is a brain. So always try to use a stopper with a marking so that you can insert a screw of 4 to 6 mm. This help us to avoid injuries related to the excess drilling to the structures which are beyond 4, 5 to 6 mm. Point to be considered here is we must have to use screws with lesser length, idle 4 mm or a 6 mm screw. Coming to the last, infraorbital. So, while reducing the fracture, points to be considered is infraorbital nerve and vessels. Our drill direction must be downward, not upward, neither inward. It's downward, it's always downward while drilling, and always take care that the length of the screw is not more than 6 mm, it must be 4 or 6 mm before drilling in this area. Once all screws were inserted in the desired holes, considered to be the most important is how to avoid the injury to the nerve, especially the infraorbital nerve. So as you see, here I am going to use a longer plate with larger number of screws holes. Why? Because the point to be considered here is the infraorbital nerve and vessel. We have to avoid close proximity or the contact to the nerve. So to avoid that thing and to get the and to give the space to the nerve and vessels, I use a larger plate with large number of holes, and I screwed only the desired holes on the both sides and left the holes in between. You also use a gap plate, a plate with the gap, which I will show you later in the video. But right now I don't have a plate with the gap in this area, so I am using a continuous orbital plate. This is a orbital plate, it's slightly curved. This is the right side orbital plate. So I am using it over the infraorbital rim, and to avoid the injury to the nerve and vessels in this infraorbital foramen area, I avoid these two holes here. One additional stabilization we can give here is the intermaxillary fixation. There is an additional fixation which we can provide to the patient, but I think this is a 3-point fixation already there, so there is a little use of it. But if you want, you can go with the intermaxillary fixation too.
These complexities make it quite a complex fracture, but the flexibility provided by bonker and the plating system give us immense control over the and precision in the entire treatment. Here I want to say, always follow the anatomy and always respect the anatomy. Always use the plates which are best suited for that anatomy. Thank you. Have a nice day.